Hello, I'm Norbert Gleicher, MD. I'm the medical director and chief scientist here at the Center for Human Reproduction. And it's my pleasure to share the stage today with my colleague and friend David Barad, who heads up our clinical IVF program and is also director of research at the Center for Human Reproduction. And today we are spending a little time to talk about IVF in women above age 40.
And specifically, how we might think differently about that compared to some others.
To, I would say, most others, because I think we should probably let the public know that national IVF data pretty clearly demonstrate that most IVF clinics after age 42, 43 basically refer patients straight into third-party egg donation because the numbers of IVF cycles in 42 and 43-year-old women are really minimal.
Minimal, yeah.
Yeah. So, and that's obviously, I would say, the most important difference between CHR and everybody else.
I think one of the important points to make is that our colleagues are competing with each other based on their published success rates, even though they were not really supposed to.
True. Well, and they are not true success rates because if you use only good prognosis patients, it's obvious
that's the point. So they tend to cherry pick their patients they're going to take through IVF cycles in order to maintain the overall center's success statistics.
Yeah.
And they don't want to risk those statistics by taking on patients who are less likely to be successful.
Of course.
And that is one of our differences, I would say.
It's a crucial difference. And it is also, for me, still totally astonishing because, I have to acknowledge it. We are old enough to be one of the few left first generation IVF. Oops.
We'll keep rolling. I'll have got it.
Okay. I am old enough, and you are old enough.
We were both there. Yeah.
To be first generation IVF practitioners. And I, therefore, still remember the days where we refused women above age 38 because we couldn't get them pregnant.
Yeah, right.
And I'm always, when I'm discussing this matter with colleagues who tell me how poor the pregnancy rates are after age 42, I always remind them that they are still dramatically better than they were in those days. And we didn't stop at age 38. We tried and we learned and we got better and we got to 42 and then suddenly we stopped.
Mm-hmm. But you remember back then, pregnancy rates even for, 25, 30-year-olds were really,
5%.
Yeah, 8%. Yeah. And I remember we used to, all celebrate and go out to dinner if somebody got pregnant. Yeah.
Yes, exactly right. But what I don't understand in all of this is kind of the lack of intellectual curiosity. Mm-hmm. How can you not want to help a woman with her own eggs after age 42?
So people who are committed for one reason or another, some people for social reasons, some people because of religious beliefs or cultural beliefs, or just because they feel attached to their own eggs, really want to continue to try. And many of our colleagues will simply refuse to care for them.
Yeah, it's really amazing. And as a consequence, over half of our patients of our new patients who come here to the CHR come with the message that your only chance of pregnancy, of becoming a mom, is through egg donation. And if that was true, we would be all out of business here at the CHR because we wouldn't have any pregnancies. Mm-hmm. So, again, I do not understand it, but I totally agree. That is a major issue. But there are other differences.
Of course.
I want to talk maybe a little bit about the difference between individualization and protocols, routine protocols.
So many of our colleagues will treat an IVF stimulation cycle in a cookie cutter kind of way. Everybody gets the same medication. Everybody gets the same suppression. Many times our colleagues will want to work in batches, so they put their patients on birth control pills or something so that all the patients will come into a cycle at the same time. And that can work for somebody who's got regular cycles and good ovarian reserve, but it really is not a good thing for people who are fighting for
every egg and every embryo.
Yeah. So the extended birth control pills they may take to just for their convenience can overly suppress an ovary so that you get fewer eggs when you finally come into your cycle. We long ago, many years now, basically have stopped using any kind of suppression.
Yeah. Well, but that is partially due to the patient population that we serve, which is so much older than the rest of the country. I mean,
but that's the point. You can't treat a 44-year-old like she's 34.
That's exactly right. And you cannot actually treat a 34-year-old like you would treat a 24-year-old.
Of course, yeah.
Age is probably the single most important factor in determining what kind of a treatment a patient should get. Mm-hmm. Yeah. And following protocol versus individualizing has really brought us a long way.
Yeah.
Our practice today in our older patients is really so different from where we were 10, 15 years ago that I'm sometimes still surprised about all the differences and all the things we have learned over the years in treating older patients with patients with lower ovarian reserve.
In terms of the sort of highly individualized approach we take, it comes down to, many things, but one of the most striking things is how we time our triggers.
Yeah.
So in the past, even 10 years ago, we tried to push everybody to have 18 to 20 millimeter follicles at the time.
Even 22, 23.
Yeah, because we thought we had to do that to get mature eggs.
Yep.
And over time, through our research and careful examination, we found that as women get older, if you push them to those larger follicles, you basically get burnt out eggs.
Yeah, we call that jokingly hard-boiled instead of soft-boiled eggs.
So the eggs end up being atretic. They end up not cleaving, not fertilizing, not making good embryos.
Don't give you a pregnancy, period.
And we found that we can, in older patients, we can trigger as early as 12 millimeters.
Even we have mature eggs from 6, 7, 8 millimeter follicles.
Yeah.
It is really remarkable. And if you had told me 10, 12, 15 years ago that I would trigger a patient at any age at 8, 10, 12 millimeter lead follicle size, I would have sent you to psychiatry.
Sure.
Yeah.
But we do that all the time, and we get nice embryos, and we're getting pregnancies in these older patients. So it's It's really quite remarkable and very different. The other correlate with that is that we don't have to suppress them because they tend not to ovulate when we trigger them that early. They don't ovulate on their own. So
we don't have to prevent them from premature ovulating those follicles. But I'm always, I must say, to this day, astonished that we even can get over-mature eggs from tiny little follicles. And it is a totally different way of practicing, and therefore probably one of the most frequently asked question from patients who come to us for a consultation, usually after they have failed elsewhere many cycles, is always, what do you do different? And I have come to a point where my answer is very short.
Everything.
I say everything. Yes, exactly.
Well, the other point is the whole genetic testing of embryos thing.
Yeah.
If you're a young person who's produced 20 nice blastocysts, okay, it may make sense to do something to select a good embryo. May make sense. Maybe not. But
Yes.
But if you've only got one or two embryos and you're 44, there's no point in really doing that.
Yeah, and it doesn't matter how you select, whether it is through PGTA, chromosomal testing,
morphology or whatever.
Or you do it through culturing to blastocyst stage, etc. Doesn't matter.
Or AI.
Yes, or AI for that matter.
Yes.
Okay, I think we have covered the issue and we need to close. Thank you for listening to us, and if you have any additional questions, you can always reach us here at the Center for Human Reproduction.